Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello and welcome everyone. My name is Renee Garrett and I'm your Speech Therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Irene Kim receives compensation for this presentation from Speech Therapy PD. She has no relevant non-financial relationships to disclose. My financial disclosures are that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia. I am also an adjunct instructor for both James Madison University and Old Dominion University. As the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on Speech Therapy PD, I do receive financial reimbursement. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Irene M. Kim, who is a first-generation Korean American, mother of two teenagers, bless you, Irene, published author, and lead medical speech-language pathologist. By day, her work is a blend of science and compassion, contributing to our understanding of the brain and body's complexities. She is grateful for the opportunity to participate in the recovery process for those affected by neurological and medically complicated injuries. She has practiced in a long-term acute care or LTac setting in the beautiful mountain state of Colorado for nearly 2 decades. Her internship was completed at Massachusetts General Hospital in Boston, followed by a fellowship at Santa Rosa Memorial Hospital in Northern California. Her first position was with Craig Hospital, specializing in spinal cord and traumatic brain injury rehabilitation. Irene is passionate about her patients, fueled by promoting their recoveries and watching the families love. She's a certified brain injury specialist, CBIS, and a certified stroke rehabilitation professional, CSRP. Fascinated by the mysteries of our brains, she is a national and local presenter of neurological injuries and their challenges. She has been featured on podcasts and is expanding her professional repertoire by providing ongoing webinars and educational opportunities. Irene's dedication to education and patient care exemplifies her commitment to advancing the field and supporting those affected by complicated conditions. By night, Irene is an author seeking to transform life's most powerful moments into the written word. Her memoir, Korea Reunited, reveals more of her life passions, including the universal language of love and uncovering the deeper parts within us, our ancestors, and their choices. It is the culmination of more than 2 decades of gathering her family stories, which led to a deeply personal account of Korea's division. Irene believes that everyone has a story and that family narratives allow us to understand ourselves. Meaning, appreciation, observing nature, and striving for internal happiness are daily practices for Irene, and she seeks to present them in her writing. Her future book will describe the medical practice of SLP, including the emotions, love, and challenges of the work through stories of patients and hospitals. Welcome, Irene. That is very powerful. Your second book, I'm very much looking forward to that because that couldn't be a truer statement.
Thank you so much, Renee. I'm very, very excited for this conversation tonight.
I am as well. So just to get started, I think you and I have talked about this, and I certainly know that a lot of people hear LTac and they think long-term care. They're hearing the LTC
The long term,
abbreviation.
yep.
When in fact, LTac stands for, I'll let you define what it stands for and what
Sure.
that setting looks like.
Yes, so an LTAC is a long-term acute care hospital setting. The long term does throw people off, and so they think we're a skilled nursing facility or some long-term aspect. But what it means actually is our average length of stay is about 25 days. And so the long-term component comes in after acute care, right? So someone goes into an ER, they have an accident, an event, a cardiac arrest, a stroke, and then they go into the ER. Unfortunately, they need intubation, tracheostomy, ventilation, PICC lines, catheters, IVs, right? So at that point, they're medically unstable. They can't go to rehab. They can't go home. So where do they go? So that's where we fall in the continuum of care. So acute care, short-term acute hospitals, STACs come first, right? Then we are the LTAC setting. The long term means it's, maybe a couple weeks, several weeks. We have the ideal outcome from us is actually rehab after us. So the patients come
Mhm,
to us to medically stabilize. Hopefully, we wean them off the ventilator. We decannulate the tracheostomy. We remove those IVs. We remove the feeding tubes, the catheters, and they stabilize, and then they're ready to move on to rehab. That is the ideal setting,
mhm,
ideal disposition. I will also say we have every single possible discharge disposition happen. So
mhm,
the rehab is our ideal. We also do discharge to skilled nursing facilities if they require a longer progress or a longer recovery, or if they're maybe not going to recover as robustly. We discharge to long-term care facilities. Sometimes we discharge home. That's kind of rare. But then also we have patients that we support through palliative comfort care, hospice
mhm,
situations as well. And so we do have patients that pass with us also. So
mhm,
I say we have the entire gamut of outcome. Obviously, we focus, or we try and focus on the rehab candidates, but we deal with the complicated patients for sure. I have two sayings that I think describe LTAC pretty well. I've honed them in. I've had a lot of students. I train new employees, and it's my best description for LTAC, and they are: there's nothing you won't see, and you can't make this stuff up. So those are the two. That's my way to describe LTAC.
I think it's accurate because when I worked in inpatient rehab, which was my first love, we had an LTAC floor. And
Mm-hmm.
so when we did we had someone who was part-time and then someone who left. So we often found ourselves covering up there, which for me was great because I was a brand new clinician. I was
Mm-hmm.
working on my CF and stayed on, for the first 3, 4 years of my career full time.
Mm-hmm.
And two of the really cool things that I found working on that floor were that we were encouraged to participate in respiratory rounds, and
Oh
we were
yeah.
encouraged to participate in wound
Mhm.
care rounds. And
Yes.
those 2 things, as scary as it was as a brand new clinician, were two of the things that taught me more about the holistic care of the patient than probably anything else I've ever done. Because, like you said, those patients in the LTAC, we had everything from someone who fell out of a tree during for a workman's comp case to someone who had West Nile virus to someone who had a spinal cord injury whose workman's comp refused to pay out, so they had to stay until they could get a discharge disposition, to someone who
Then
had head and neck cancer with a TEP that
yes.
kept getting infected.
And
I
then
mean, it
there are
was
those
really literally
cases,
everything.
literally everything. And then there are those cases that are complete mysteries. No one can
Mhm.
figure them out. Absolutely no one can figure them out. And sometimes we can arrive at some of the answers, sometimes we don't. And
Mm-hmm.
that's the, that's it's where my heart is trying to figure those mysteries out, because it's, the body is the brain, very complex, right? And
Mm-hmm.
sometimes we get the patients that really no one else knows what to do with. So
No,
sometimes,
I think that's very true, and I think sort of understanding what the role of the SLP, because it's not your standard, "Let's go in and do a swallow evaluation on a
no,
patient who had a stroke and now they're awake and they can
mm-mm,
participate in an
that's right.
instrumental exam."
That's
Yeah,
right.
so talk to us about that. What does the role look
Oh,
like from
so
because
that's
there's
a
no
really,
general role.
absolutely, it's a really good question. I would say, obviously, we have the clinical role, but I think we have a lot of counseling role, a lot of
Mhm,
support role, a lot of emotional support where, we may or may touch on that a little bit in grad school, but I think maybe not. The pure, sometimes you really are a therapist in there, and you're just
mhm,
listening to the family, and you're just listening to the patient, and you're counseling them through the worst times of their life, the most devastating things that they've ever been through, especially cases that go in for elective procedures. Young people that go in for like some sort of maybe an ENT procedure or something that goes wrong, and then they're anoxic
mhm,
and they're on the vent, right?
mhm,
And so complete shock, a state of shock. And so that counseling piece really comes in as you're guiding them through the clinical pieces, right? But I feel like we're also a presence for them, and we become a familiar face, and we become not only their clinical go-to, but their support go-to. And it's from day one to discharge, right? And so I think we hold a lot of role there. And then I think our separate role, also not separate but combined, is our educator role. So
mhm,
we're educating not only the patients and staff, but I do a lot of, so I do our hospital orientation, new staff orientation every month. They come in, they don't know what cognition is, they don't know what brain injury is, right? So that our new staff orientation, our new hires, they are CNAs, they're RTs, they're nurses, they're dietitians, right? And so our role is to educate how we fall into this continuum and of care, and how we can collaborate also. So the education piece is enormous in what we do. Speech therapy, what is that? We talk fine. I talk fine. What's it? And so you have to define, and I always say, I wish I could come up with a better term for us for this setting, because speech
yeah,
therapy, no, it doesn't, it's not quite, it doesn't capture what we do, right? And people, I try and explain, and they're like, "Why do they call you speech therapists?" And I'm like, "I it just, it just is what it is, but let me explain a little bit further what we do." And so I say, we're involved with the upper respiratory system and up, right? So the upper airway, the swallow, the trach management, where you mentioned pulmonology. So yeah, we round with our pulmonologist twice a week, our RTs constant daily. They'll actually call us before they decannulate, right? And then
mhm.
I have had the privilege of building a neuro program, a brain injury program within our LTac. And so I round with our neurologist one on one every twice a week. And we go to
Oh, that's
yep.
awesome.
It's very much, it's a extreme privilege. But within that is just, it is a lot of education. And so the patients see me rounding with pulmonology, rounding with RTs, rounding with neuro, co-treating with PT and OT, right? And so we'll get into a little bit more of that, but it's very tight, is interdisciplinary roles in this setting.
Yeah, and I think it's probably the closest interdisciplinary to inpatient rehab, which is probably why in our inpatient rehab we had that floor to begin with. Was it
Yeah.
was a similar setup in the role of everyone working together, where it seemed, and I say that because I worked at acute care where there was this big hierarchy of doctors are king, nurses are queen, and
Mm.
therapists are good luck.
No, that's
And
no.
in inpatient rehab, it was not. In LTAC, it was not like that. At least where I was, it was
Mm-mm.
more
Mm-mm.
people depended on me for certain things, and I depended on them for certain things, and it really
Yep.
was a true team effort. But I
Yes.
love what you said about the roles of SLPs, because a couple of ways that I always explained it was, I tend to work the hospitals I've worked at tend to be not always higher socioeconomic status. So I always say
Yeah.
here and up is where I work. Same muscles and nerves you talk with, you swallow with. And then when I say that, they're like, huh. And then I say,
Right.
and your brain is in charge of everything. It's like the computer of
Right.
your body. And once you say those things in terms that people can relate to, I think not only do they understand, but it does build that trust and rapport
For sure.
with the patients and the families, because not everybody is educated at a master's or higher, or a bachelor's or higher, or even a high school education. So if
Yeah.
you could put it in terms where people understand our role, I think it's really helpful. And then the other piece that I kind of wanted to play off of what you said was that
Mhm.
a lot of times for us, if we're not co-treating, we're one-on-one a lot more with our patients, because we don't necessarily tend to treat them in a gym-like setting. We're either in the patient's room or the patients are in our treatment room, which builds this more intimate setting, right?
Mhm.
So we're one to one, or we're one to two if it's us with the caregiver and the patient. And so they do tend to have this safe space where they can open up and share more, not just
Mhm.
about their life, but about their expectations, about how they're feeling about the day, how they're coping with all this therapy that they're now getting, and this medical event that's changed their life. And I
Absolutely.
think it's a really crucial role, and one that I've always really embraced and enjoyed. So I'm glad
Same.
that you made a point to say that.
Absolutely, absolutely, and I think, the co-treatments and the multidisciplinary, when they see us, not just in our individual sessions, but then they might see us at one-on-one, but then I'll go and I'll co-treat with PT and OT. Then they'll see me come in and round with our neurologist. Then they'll see me come in round with our pulmonary, like every single discipline, and then we have, of course, nursing and the team rounds, right? And so they start to see you in more than one setting with
Mhm.
more than one discipline. It's all in there together. It's all in there together. So we definitely have to break out of our body systems that we focus on, but yet still encompass every single thing, head to toe. I'll
Mhm.
have them wiggle their toes. I will take a left hemi and I'll say, find your left arm and grab this toothbrush with me and do your oral care, right? And so they start to be like, oh man, she's doing it all, right? And so I think as SLPs in this setting, we really can draw on every single thing that the patient's going through and incorporate it into what we're doing.
Yeah, I think, and that's no different than, when your patients are starting to be able to eat orally and they're learning how to self feed.
Yeah,
Our
100%.
patients with apraxia who, can't get the tool use correct, or they can't initiate the tool use, and they know it's a fork but they can't remember how to use the fork, and you get them started. and
Yeah,
and we have, OT does a lot with that too, but if
yeah,
we're working on dysphagia therapy, and part of that is stamina during the meal, or we're looking at trials and their ability to be ready to participate in an instrumental exam, which, I mean, I'll participate you in an instrumental exam before I think you're probably ready, because
yeah,
we need the baseline, right? But
yeah,
if we're able to help that patient guide the cup to their mouth, or pick up the eating utensil and help them get started, because a lot of times with our patients with apraxia, once we get that first one going, they can do it. They just need that help. So I
exactly. Get
think those
started.
are,
Yeah,
yeah, those are
yeah,
really great examples, because we have to start at the beginning.
yeah,
Right, and when the patients are seeing that we're not just looking at the swallow part of it, we're looking at the holistic picture of what do you
100%.
need to get back to your independence.
Yes,
So you've
absolutely.
already kinda touched on the professionals that we collaborate with, but, um, it one of the things I kinda wanted to take a deeper dive into is, it's kinda twofold, because I think this is really important. The role of working with a dietitian to me is very crucial in that
Very.
setting,
Yeah.
especially because of the wounds that we often see in patients
Mhm.
who've been bed
Oh, yeah.
bound for long periods of time. So is that something that we can kind of delve into?
100%. Even the TBIs. So the dietitian and I have created nutritional requirement handout for TBIs. It's way more
Yes.
protein, it's way more calories, also CVAs. So the dietitians, yes, are very crucial. I did want to make even a couple more points um, about who do we collaborate with. I would say
Yes.
there's no one we don't collaborate with. No one.
True.
There is
True.
I am talking housekeeping. I'm talking
Yes, I was
dietary
thinking.
clerks. I'm talking, right, the janitor, the one who does the floors. So here's how I think about it. And I go through this with when I do the staff orientation and I don't know who's going to be, it's whoever they've hired, right? So, but I think of maximizing every single interaction, everybody that goes in that room, right?
Mhm.
So our dietary clerks will pick up the menus from the patients. Our housekeepers go in and they're wonderful, and they will
Yes.
just interact hi, and they'll just talk to the patient. And I think of it as, if I'm a patient and I'm lying in this room 24 hours a day, right? I do have many people coming in and out. I'm not going to know who they are. I may not,
Mhm.
the lower levels, I'm not going to remember who they are. But at those lower levels, if I get interaction from every single person that comes in my room, that's going to spark more. That's going to do more, right? If I
Mhm.
say to our dietary clerk, hey, when you go in, could you just, kind of remind, at least, hey, today's January 13th, it's Monday. Great. You know what I mean? So that's my
Yeah.
approach also in that
Yes.
interdisciplinary. It's not just the obvious co-treat with PT and OT, the rounding with our hospitalists, nursing. It's every single interaction that happens in the room. And then that's
Yeah, encourage people to treat people like they're human because they are.
yes. Yes.
Yeah, I say that to my students too all the time. Even my students that are not I'm talking about my university students. I say,
Yeah.
how would you feel if that was your grandmother? How would you feel if that was your mom or your sister, or your cousin or your best friend?
Or
How would you
you.
feel if yeah, or you, if you knew that someone came into your room and never said a word. They just came in and started doing all the things and stuff, and you're laying
Yes.
in
Ugh.
this bed
Yeah.
unexpectedly, helpless, can't necessarily communicate independently, nor eat or drink independently, or get up and go to the bathroom independently. How would you feel if people just came in and out all day
I didn't
and
say
never
a
said a
word.
word
Yeah.
to you?
Yeah.
Yeah,
Yeah.
yeah,
Yeah. Yeah. So there's no one that we don't collaborate with. Thinking outside the
yeah.
box for sure. Yeah.
I love that. Yeah.
Yeah.
No, and we had even in acute care during the pandemic, we had a lady that had been environmental service worker
Mhm.
long before I came there, and I had been there for 10 years before the pandemic happened, and
Mm.
her kinda claim to fame behind the scenes was she's a older African American lady, very, very faithful in her religion and would sing hymns,
Mm.
particularly to people who were post-CVA who were not yet awake. She just that was just her thing, and she actually got told not to do that because a staff member got offended, and I
Oh.
I kinda
Yeah.
got in trouble because I
Oh,
advocated for her to keep doing it.
I would
I
do the
just didn't
same. That
yeah,
I
like,
mean,
what do you why? It doesn't for that level of care she was giving, it didn't matter what the faith of the person was, it mattered that
right,
someone cared enough to go and then try to provide an encouragement to this person who, didn't ask to have a stroke, right?
right.
Because you don't that's not something you're like, "Oh, yeah, that's me, I wanna have that today."
No, I
And that's
wanna
the
be
same
here. Yeah, I often think of, like,
yeah.
one of the silliest questions we ask patients are, "How you doing? How you do how's it going?" "Oh, it's
"How you
great.
feeling today?"
It's
Yeah.
great. It's great. I'm sitting in this LTac for I'm great." But yeah, yeah, I
I had
probably
4
would've got
surgeries in 3 weeks. Yeah, I feel great. Thanks
yeah,
for
I'm great,
asking.
thanks for asking. But I would have gotten in trouble as well because I would have encouraged that. That's a beautiful thing. Someone going in and
Yeah.
singing, it's don't think of that like that human aspect, right?
Yeah, the
And
human
yes,
connection, for sure.
yeah, I
Yeah.
would have gotten in trouble too.
I'm good at getting in trouble. It's fine. I'm
I
not going to
I
stop
am a
because
pain in the butt for sure.
yeah, when it comes to advocacy, I feel like sometimes, again, I'm with you. I think outside of the box a lot. I was a
Yeah.
family member before I was a therapist, and so
Yes.
I think of things differently that other people may not see or think of.
Yes.
Yeah, and I think when we're thinking about, our role too in looking at the dual tasking, when you talk about the co-treats,
Yeah.
a lot of what we do already is dual tasking, but a lot of people don't realize that's what they're doing, right?
Mhm. Mhm.
Because especially in our brain injured population, we're asking them not only orientation questions, but at some point we're asking them to visually attend to a schedule so that they know where to be, or they know that they're going to have therapists coming into their room at XYZ time, or we're making them accountable for making choices for appropriate items from the menu that they get presented with,
Mhm.
right? So
Mhm.
there's a lot of ways that we already dual task with our patients where I think people aren't necessarily realizing that's what they're doing.
Sure.
So what are some other examples of the dual tasking that you're talking about or that
Yeah.
you
Yeah,
this
so,
with?
the definition of dual tasking, right, is motor and cognitive tasks simultaneously with separate and identifiable goals. So, if you've got each discipline should be going in there with their own goals, but they're very easily combined. So, I would say we have so I kind of break it down into lower level and higher level. So lower level patients, they're the ones that we are trying to just fire those sensory and motor neurons into the prefrontal cortex. We're just giving that multisensory stimulation to get them firing and processing information. So something that we do that I do with my PTs, OTs a lot is lower level, right? So you take that Rancho 2 or 3 patient and they go in and they sit the patient up, right? But then what? So that's where I come in and we're not just sitting up, right? We don't want to just fire the prefrontal motor. We want to fire as many pathways as we can. So they'll sit them up or we'll get them onto a tilt table or a standing frame, whatever they
Mhm.
can handle. And then I'll come in and I'll make them smell hot sauce or I'll put a little lemon flavor in their mouth, or I'll make them smell, right, those olfactory centers right here. And sometimes when they're sitting edge of bed with PT, they'll just be out, right?
Floppy, yeah.
You
Mhm.
can move a body, right? They're just sitting, but they're not aroused yet. They're not alert yet. They're not, those attention pieces, that foundation of the cognitive hierarchy, they're not there yet. So then when I come in and I do those multimodal stimulations, they'll actually wake up to that. Then we've got
Mhm.
them, right? Then we've got them. And sometimes I will use stimuli that's not super pleasant, right? Making them smell bleach white, making them smell mustard. I
Mhm.
I will do anything and everything, within reason, to get the patient going because the way that I think about it is their brain is completely depending on what we give it.
Well,
Completely
and
dependent.
a lot of that is the basic coma stem that we used to be, I feel like, a lot more part of. And again, I think being in that LTac setting, being in acute care, if you're in a neuro rehab or a neuro
Mhm.
ICU,
Mhm.
that's what you're doing. You're doing a lot more coma stem because you're trying to arouse the patient past the level of just being able to sit on the edge of the bed. You're trying to engage something else that's going to, again, like you said, promote that level of alertness or awareness. And a lot of that is noxious stimuli.
Yes.
It's alcohol pads under the nose, right? It's smelling something strong.
It's playing
Um,
music they hate.
yeah. Well, and when I was a student, and this wasn't a noxious stim, but it was a something that my CI told me she had found with patients with dementia who were cognitively pretty impaired and had stopped eating. A lot of it was
Yeah.
they didn't have someone helping them assist them with eating, even if they were safe to do so. but
Right.
they had lost their sense of smell. And so what she would do was do something like an apple cinnamon flavored candle or an apple cinnamon sort of scent in the room. And a lot of times that's exactly what would happen was PT would come in and get them positioned really well for a meal, and she would have some sort of scent with that apple cinnamon, and all of a sudden you see this. They're looking, they're
What
tracking with
is
their
that?
eyes. They're like,
Yeah, right.
"Yeah, where is that? Where is that thing that smells so good?"
Right.
Um,
Yeah.
and I think that's good. Also, like you said, the noise, and it doesn't have to be unpleasant noise. It can be
Yes.
uh,
Of course.
classical music
Yeah.
too. People aroused to that, or recorded
There.
voices from their family or their
Oh,
loved
yeah.
ones.
I
Yeah,
love
I've done that.
I love, the state of the world now. We get their people on FaceTime, right? Where
Yeah.
we put a phone. Oh, yeah. I put a phone in people's hand, and it's amazing what that does. They just
Mhm.
go right to it. It's like we're all so automatic with it now. But
Yeah.
yeah, and going back to dual tasking, there's so much evidence. It is so evidence-based, right? We could go on and on and on. And here I can throw a couple into the if you wanted to throw a couple names. I have Pinho et al. 2020. And what they did is they actually showed some mapping of activity during various tasks, a lot of different tasks. And I have just three examples. One is they showed what lights up with hand movement. They showed what lights up when you're listening to a sentence, right? Which is us giving the commands. They showed what lights up with tongue movement, right? So all areas of the body they kind of mapped out, and they showed this activation. And so when you are dual tasking and you're doing hand movement and you're given a command and you're activating that motor strip and you're working with the tongue, you're giving them that taste sensation, right? There's so much activation that happens. And then there's another name I can throw out, Papagital. That'll be a hard one to
Yeah.
spell. But the point there is just there's a lot of studies for increased activation, dual versus single motor tasking. It's very visible on fMRIs. And it's
Yeah.
common sense, right? It makes sense. So you've got all these studies going on that are supporting what we're doing, where we're just driving that neuroplasticity to the max, right? And so neuroplasticity is a whole other topic. There's no lack of research there. So there's so much, because what we're trying to do with dual tasking, what we're trying to do in general with rehab, is minimizing those maladaptive behaviors that are trying to take over after injury, right? So we are trying to really minimize that by maximizing function, maximizing engaging not just the cog pathway or the language pathway, but the motor pathways. And when we engage both, there's so much more. Axons sprout, synaptic connections are reconnecting, right? Pathways are happening much more than if we just stayed to one path, right? So
Yeah.
here's a much easier one to spell is Su et al., SU et al., 2016. And they're the ones that did a lot of research in terms of the new synaptic markers, the axonal sprouting that happens weeks after injuries. And these are the cortical changes for the recovery that we're trying to drive. So, activity dependent reorganization, right? These are all
Mhm.
keywords, all these things that we've heard. But so, in terms of dual tasking, there's just such a push for it. When I did that presentation at a PT conference, this was last fall, I used that opportunity to teach them about cognition.
Mhm.
And so I taught the cognitive hierarchy, and I talked about how we build the foundation of attention, then we build on that with memory. If we can't attend, then we can't remember, right? So the PTs, they go in and they're used to just giving commands, right? And they
Mhm.
give command and command and command and command. And so I kind of taught them to think through, take a second and think of how many commands you're giving, right? And if you're having to give the same command over and over and over again, is that really working? It's not, because they're clearly not remembering if you're having to say the same thing
Mhm.
over and over, right? So I teach, why are they not remembering? How are we going to get them to remember? And so with the co-treatments, there's just so much there. I have our PTs think about, okay, think of the two things that you need them to remember in this session, right? You can't just tell them and then leave. How about writing it on paper and putting it on their wall, right?
Yeah.
How about having them think through, what two things went right during your session today? And what
Mhm.
two things should we maybe do differently tomorrow? And leave them with something to think through. So if it's okay,
Mhm.
I have a couple of quotes from PTs that I wanted to share,
Yeah, of course.
because we do a lot of co-treats in the LTac, and I think it's very much a luxury. I'm so glad that we can do this. But two PTs that I recently worked with, and one, basically they were both navigation. They were pretty higher level patients. They could get up, they could navigate. One was a CVA patient, another was a brain abscess patient. And I went in with one before the PT. I said, what do you want to do in this session with them before we go in? And he said, I want to get them up and ambulate down the hall. I said, okay, great. So then I go into the patient beforehand and I said, okay, so I'm going to work with PT today and we're going to get up and ambulate down the hall. How much help do you think you're going to need on that? Right. So I get him thinking. And then I actually have created a rating scale that we use. So I'll ask them to rate themselves on these tasks. I'll ask PT to rate them, OT, nursing, family, right? And the ratings should be kind of the same across the board, right? If
I
you've got a
know.
patient that's like, I don't need any help. What are you talking about? I'm a 10, right? I don't need any help at all. What are you talking? And then the PT is like, actually, he's a 1. He's totally max dependent, right? So we so these for these examples, I really touch into their executive functioning, right? The penthouse of that cognitive hierarchy. So at the end of that session, this PT told me, we're so used to just doing. I like how
Mhm.
you changed the pace and made him stop and assess the situation, his body awareness, and decreased his dependence on me.
Mhm.
I'm going to incorporate in I'm going to incorporate all this into my next sessions.
Oh, that's
Um,
awesome.
so that's one thing a PT told me. Another thing, a different PT told me, I like how he thought through his functioning more. Then the next day, he walked better than he ever has.
Oh, that's amazing.
Yeah. So, going back a little bit to our role, I think is that education piece with our colleagues, and I also learn from them. Right.
Mhm.
Every single day, I've been doing this more than 20 years. Every single day, I learn something. So, yeah, the dual tasking piece is a really big one, and I think we have a lot of space within that. I think the PTs, when I ask them questions like, how would your session look like if you said nothing, if you didn't give any commands at all? And they're like, what are you talking about? How could I, what? Right? And so they're not even thinking about, oh, I need to be teaching and pulling back.
Yeah.
They need to start leading the session, right? That's our
Yeah.
ultimate goal, is for them not to need us, right?
Right, or having them at least teach back when they're able to teach back what is it you ask them to do, because that's
Yes,
also foundational attention and working into the memory is having the patient once they get say they're, at the basic level of 1, maybe a two-step direction. Give them the one step, have them teach that back, have them then
yes,
incorporate the two-step, teach it back, then execute, and then when they're done, teach it back again, because that's really better not only exercise principles, but that motor learning piece. Again, and I go back to my university students several sessions, several sessions, several years ago. a lot of the students were solely reliant on their laptop, but what we were finding was a lot of them were doing other things. I probably did that too when I was a student. I'm not even gonna lie. I probably was in my 7:20 to 10 p.m. research methods class.
Oh, right.
I'm
Of
grocery
course.
list making. I'm
Uh,
shopping. I'm doing something else.
right.
But what we found was that a lot of the students weren't attending, and then they were doing other things on their computer. So once I
Yeah.
started walking around the classroom and watching them not take notes, one of our professors actually, it was our graduate program director, who said for like 2 semesters they couldn't bring laptops into the
Oh,
program.
wow.
They had to actually handwrite their notes because she wanted to see if there was a difference in their motor learning,
Oh,
incorporating
interesting.
the motor learning piece of
Sure.
handwriting versus typing, because it doesn't require as much work. And so the
Absolutely.
students hated it, but
I
it's
bet.
very similar to what we do with our patients, right? Because we want
Right.
them to not only attend, but then
Yeah.
to recall. And the best way to see if they're able to do that is to have them do teach backs throughout. Or, again, for those of us who aren't working in a inpatient setting anymore, the same thing with a home exercise practice. But in your setting, it's a room exercise practice, right?
Yes.
Because you're
Yes.
probably giving them something to do in their downtime where they have to recall what the directions are and maybe teach it back to you
Yes.
prior to doing it or after doing it, or both. Again, we're looking at various levels of cognition,
Yeah.
various levels of language, for these patients with a lot of anoxic and traumatic brain injuries. And there's a lot of different ways to do it.
Yes.
But I
And
think it's a good one.
the ultimate goal, regardless of the condition, is their maximized independence.
Hmm.
So we're always trying to tuck back, give less cues, give less commands. You lead it, right? No matter what their injuries are, that's the ultimate goal, right? And so the PTs will be like, I have to say the same thing every single day, and I'll be like, okay, so maybe we should think through doing things a little differently than just giving the command that we know they're never going to remember. So I'll
Hmm.
put bright paper on their TV because they're watching the TV, they're looking at the TV. Everybody looks at their watches their TV. So I will put a bright, obnoxious, neon colored paper with safety steps. I'll say, plant your feet on the ground before you stand up. Reach back on your wheelchair before you sit down.
Please don't
Put
go on.
stand up straight when you right. I will put those PT safety goals again, that co-treating, thinking outside
Mhm.
my box, think through it, right? And I'll just be obnoxious about. I'll be like, they can't not see it, right? And I've
Yeah.
even had docs, the hospitalist walks in and they round on that patient that day and they'll be like, "Oh, so those are your safety steps. Why don't you tell me
Mhm.
what you do with PT? Look at that. Look at that sign." Right? So then again, you've got housekeeping going in there. You're taking every single interaction and you're giving something very tangible that everybody can see and everybody goes to and everybody reviews. Oh, now they're starting to remember it.
Yeah, and well, the CNAs, the certified nursing assistants, they were
Huge.
great for that because
Huge.
a lot of times they were doing grooming tasks with the patient, they're doing their bath with the patient.
Yeah.
They're saying,
Yeah.
"Hey, Mr. So and so, you had a fall yesterday. Why did you fall? What was the thing that you missed? And what's
Yes.
the number one answer? I didn't lock my wheelchair." Right? Or I didn't call on my call light before I got up and I knew I had to go to the bathroom, but I didn't push the call bell before I got out of bed and I fell. Those are probably the 2 most common things you hear
So
because
common.
people push the call bell and they've got to go to the bathroom, and maybe it's too long
Well, yeah,
before the person can come in and help them, and then they get up because they don't wanna be incontinent.
I know.
So they're trying to get up and go to the bathroom, but
Mhm.
then you have the other patients who, are in their wheelchair and can maybe get up to stand and brush their teeth, but they forget to lock their wheelchair, and they're in the bathroom, and they get up, and then they're in the floor because they didn't lock the wheelchair.
Yes.
So
So, yes, and I
it's
often
it seems so basic, but it's really not.
it's not, and it's so hard because the patients are going through so much, right? And they just
Yeah.
have so much coming at them all the time. How can we expect them to remember? And so it's that's why I do a lot of signage in the rooms, a lot of signage. We even create like little daily logs for patients and they'll write it, right? So it's that multimodal, hear it, see it, write it, read it over and over and over again, right? Then we bring the families in too. So yeah, there's a lot to be said about all of these things. But yeah, approaching a patient collaboratively, I think a lot more gets done that way.
Yeah, I think so too. Have you been a part of, and it sounds like you have, which is why I'm asking this, have you
Yeah.
been a part of expanding not only the visibility of the SLP as a role
Oh
or a
yeah.
team
Yes.
player, but as far as like the into the maybe standards of like education in the hospital, or
Yes.
you mentioned the new employee orientation. I know
Yes.
for me, one of the things that I got involved in was the stroke education. That was a group activity that also their family members or caregivers could come to. So, what are some ways that you've been able to kind of integrate the role of the SLP into those bigger
Yeah.
tasks that sort of don't involve us unless we make
a-
noise?
Absolutely. Yeah, I would say I'm a very proactive person. So I do a lot. Even I work with our navigators, our clinical
Mhm.
navigators out in the field. I've actually even gone out with them before they bring patients in. So assessing patients and educating our clinical navigators as they're out in the community, seeing if they're assessing their case, asking the nurses and the doctors over there at the previous hospitals, what are the exact questions that we need to ask? How can we prepare for their admission? So, what I'm big on is streamlining communication throughout the entire stay. So, it's pre-admission, it's at
Mhm.
admission. I'm the presence where I greet as much as I can if I'm there. I'll greet the families. We have certain signage. We have a certified brain injury program, which that's a whole other thing that STs can really be part of is developing programs, certified programs, neuro programs, cog programs, dysphagia programs, volunteer programs. So building programs and facilities is a huge, huge way that STs can be involved. Streamlining communication throughout the stay. So you know the patient before admission, we prepare at admission, we greet them at admission, we treat them throughout the stay. We see them with pulmonology, neuro, RTs, PT, we see them throughout. So then in this way, I feel like we start to become the go-to people, right?
Mhm.
We become not only in our area, but in the team.
Mhm.
So to me, that's something that I've built in our facility. So everybody in our facility knows STs really well. They will come, they'll page us overhead, they'll call us, they'll seek us out as the go-to people for a lot of things. Will be that educator who can answer questions. And if not, if we don't have, because we don't have all the answers, but we'll be able to direct them because of that multidisciplinary approach. So in terms of expanding ST role, I feel like developing programs, staff orientation also can include developing competencies. So obviously, like every facility, we have these competencies every year online. We also have what's called a skills fair for us, which is
Mhm.
every employee has to go through it. And so I'll do the neuro cog portion, dysphagia, and I sign people off on those competencies as well. So those are big. And within those education pieces, I do a lot of role plays. So I don't do a lot of talking. I do a lot of like educating. I'll be in a bed and it's that skills fair, right? It's just the so I'll be lying in a bed in a horrendous position. and I'll say, I want you guys to position me to eat. Right? So those really hands-on things where I'm not just like talking at them. I'll be like, I'm gonna be a patient, and I want you to, position me in the right way. I'm gonna be a Rancho 4 patient, and I want you to redirect me. I'm gonna be an aphasic patient, and I want you to communicate to me, no words. We're both aphasic. How are you gonna communicate to me? Right? And so I'll do it in a friendly manner, but they'll be like, "That was awesome." Right? And then so
Mm-hmm.
the next time they see me on the floor, they'll be like, "Oh my god, that was awesome. I have an aphasic patient now." Right? So I think there's never-ending ways that
Mm-hmm.
our discipline can really expand in any facility, right? All of these things can apply to any facility. But I think there's a lot of room for it. And I think, it's hard as perhaps new clinicians. A lot of it is built into experience,
Mm-hmm.
right? Once you have more experience and more research behind what you do, evidence-based practice is huge. I find what happens there is you start to build this confidence in what you're doing, and then you're able to explain why you're doing it, and then you get that buy-in from the patients, the families, the staff, and everybody knows you know what you're doing at that point, right? So I think there's a lot that can be done across the board throughout the entire stay, working with every single discipline at every point in the stay. And so even case management, I didn't mention every discipline, but every single discipline, I would say there's not any discipline that we don't interact with and that we don't have a role that we can expand
Mm-hmm.
within. So,
Yeah, I think that's very true. And I'm thinking about, being when I was doing my CF and in inpatient rehab and in the LTac, the really interesting thing for me is that because we do a fellowship,
mhm,
I found that I sort of felt like I was this in between student. I had graduated, right? I wasn't a student, but then I was still sort of a student because I was a
sure,
fellow. And so I find that for us as SLPs, we tend to be, if we are able to co treat with PT and OT, we're asking them a lot of questions. We're
yeah,
talking about positioning. We're talking about adaptive equipment for self feeding. We're talking about dice them under plates and all sorts of other things. But they
mhm,
don't always come to us the way that we come to them. So I think providing those concrete examples at safety fairs is really crucial because the safety
yeah,
fairs that we tend to do are a science project trifold with like pretty pictures of diets and textures and what is aphasia and it goes to like expressive and receptive and no one
eh, yep,
gets
and
it because they're like they don't get it and they
no,
don't come and ask questions.
that's
We
why
sort of have to
yeah,
force ourselves down their throats.
that's right, that's why I put them in specific role plays, and, they don't they really enjoy it, actually. They enjoy
Yeah,
it, and they remember it that way. Yeah, that's
yeah,
just my
because I think
style.
we're more cerebral and I think they're more physical. So they're used to doing these physical manipulations and getting all up in your personal space where we're used to thinking, okay, how can I make this task less complex or more complex based on what the patient needs are? And we're not necessarily always going in and touching people. So I think it's, again, much like we do with our patients of meeting them where they're at, we have to meet our disciplined, multidisciplinary teammates where they are and what their expertise level is. Because then once you do that, they will be happy to teach you. But then if they're stumped, then they're going to start coming to you and reciprocating that need for
Yeah,
knowledge from you because they don't, just like you mentioned at the very beginning, much of the time our patients don't really understand what we do. Our colleagues, if you haven't worked with an SLP, our colleagues have no clue what we do.
right,
And so when you're able to make that bridge and that connection, I think it's very helpful for them because
for
they,
sure.
again, develop a level of trust and they start
Yeah.
to really include you and incorporate us as part of the team.
Yes, absolutely, and I've had the absolute privilege of doing it in my facility, and it's something that I've had to grow into for sure. It's not something we come out of grad school with, right?
Mm-hmm.
We have to really believe in what we're doing and have the evidence behind what we're doing, and then build that confidence and educate. And then, I will say, I do have people seek us out because it's kind of you have to kind of create the presence of
Mm-hmm.
SLPs in where
Mm-hmm.
you are. And then it starts to happen pretty quick,
Mm-hmm.
actually. And if you can get in front of all of the new hires, right? So then they come on and then they see you on their first days and they remember how you oriented them. They remember those weird role plays that you do. Oh, I remember you made me position you in that bed. Okay, well, now I know. And then I watch them do it, and it's just beautiful, right? But you
Yeah.
think of ways where you're actually going to grab them and they're going to remember, and then you see it happen. There's nothing better.
Yeah.
Nothing
And I
better.
think that the similar thing with nursing, I always said in acute care, nurses were my best friends because they are with a patient so much more than we are. And so
Yes.
if there's, and just like with long term acute care, if there's an acute change, they typically will pick up on it. Or if you pick up on it because you've been with this patient for 2 weeks and you go in the next day and you're like, oh, something's off.
Something's off.
That's
Are
not,
they septic? Right. Right.
yeah, something's going on and you go and talk to them. They're like, "Yeah, I didn't have him yesterday, but I had him today, and I noticed that Friday he was a completely different person or whatever." So it's again having once you develop that rapport, one of the and I'm not tooting my own horn when I say this. It's just I think it speaks to your willingness to collaborate and make these relationships with your teammates because when I left acute care, that was one of the things I heard from particularly at the ICU nurses was it's not the same without you. The other people don't come and talk to us and get the information that you did. And I'm like, well, sorry. Sorry
I
about
know.
that. But
Great
that's
that
just
you
how
did
I
it.
operated. They've been there, if I worked a Saturday in ICU, typically they would work Friday, Saturday, Sunday, the weekend nurses, and they have already been with them. Say I wasn't working on Friday and I came in Saturday morning to do an eval on a newly decannulated patient. They had already been with them after they
Yeah.
got decannulated and prior to that. So they had a lot more information to give me than I
Right.
had to give them.
Yes.
Right? And so
Yes.
you foster those relationships
Yeah.
because then you can go in and say, we're planning on doing a modified barium swallow on Monday. Can you at least when you leave, can you leave notes for the nurse that's coming in to let the morning nurse know if they're appropriate? Because again, septic is
Yeah. Yeah.
happens quickly, right?
Oh,
Change in status happens quickly. And so we need to make sure that this patient's awake and alert and can actually tolerate not only transferring downstairs to go do this instrumental exam, but can they sit in the chair? Do
right.
they have a new wound? Is there a
Yeah.
pain medicine change? All these things,
All
right?
these
Um,
things.
yeah, there's
So
so
many
many
things.
pieces.
So many
Yeah,
things.
it's
Yes.
constantly juggling and trying to keep up with all that, but having those people that are your backup plan, your second
Exactly.
set of eyes, your third set of eyes.
Yes,
Yeah,
absolutely. Absolutely. Multidisciplinary collaboration, huge. Absolutely huge.
yeah, I agree. Anything that you would love to add to what we've talked about? Any other research or any other case study, anything like that that you'd like to talk about in their last couple of minutes?
I guess I have one more case example that I just loved, and and we presented this at the PT conference also, but we had a patient who had a right brain abscess, and he was a left hemi, and he was that higher level guy, but his insight was not great, and he was like, "I'm fine, I just got to get you have I got to go home. I got to get out of here. You have no idea how hard it is to just lay in this bed, right?" So my PT friend, colleague, and I worked together, and I wasn't thinking it was going to go great. He was like, you know, frustrated. He wanted to leave. So we got it. We worked with him together, and she wanted to do a step and work on his balance. So he could stand fairly well, And then we had a step in front of him, and she was working on his weaker side. And then we have on the wall, we have cards placed on the wall. And he was holding a flashlight as he was stepping up, working on his balance. And I had him shine the light, A1, B2, C3, right? And they're all spread out. One of our students did this for us. And so we had him, step up and down and do that at the same time. And it was, he lost his balance and he was like, oh, whoa, right? So it challenged him, right? Those more pathways are going. And I actually thought he was going to get like mad at us and like frustrated, but he was like, at the end of the session, he was like, that was fun. Let's do it again. And we were like, really? And he ended up going home. So
that's
his
awesome.
recovery, his recovery was great. I just wanted to share that one success story. And then I do want to say all of this is such my passion. So I do, I'll be diving into this a little more. I am going to do an hour-and-a-half webinar through Speech Therapy PD next month.
Good.
And it's a CEU for credit also. So yeah, I'm really looking forward to that. That's based on a presentation I did here in Colorado at our national conference. So I'm diving into neuro a little bit more on that. And it is my passion. I could talk about this all day long.
Same.
Right. That's why we do what we do, right?
Right. Well, I look forward to that. I'm hoping I'll have to look that up and see if I could be there and join in because I would love to.
Oh, thank you. Thank you so much. This has been wonderful. I really enjoyed our conversation. Really appreciate this opportunity.
Me too, Irene. Thank you. Yeah, thank you for joining us. It's always nice to have someone on who has a passion for neuro because I say weird things like, I love a good brain injury. And then I'm like, oh, sorry.
I
Sorry about your
know.
brain.
I know. I actually made the I know. I've made the mistake of saying the brain is fascinating. Like, this patient's fascinating, right? And
Yeah.
the family member was like, they're not fascinating. They're my family. And I was like, oh no. But they are fascinating because we get to delve in and fix it, help it recover, help it heal.
It's a challenge, I think, for us too. And then a lot of times that's the patients that we see so much recovery with. Hope, fingers crossed, knock on wood, whatever you do for whatever.
Right.
But those are the challenging patients that push us to learn more, be better, do more, learn more. So I think that's a great place to end. So Irene, I thank you for being on here and sharing your knowledge. And again, I hope that I can be part of, your audience at your webinar. And we certainly look forward to that.
Absolutely. Thank you again so much. This has been great.
Again, thank you. And we look forward to seeing you again.
Thank you so much.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Each episode comes with an accompanying course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code BRAINSTORMS20. SpeechTherapyPD.com is run by SLPs for SLPs. We've got the largest library of ASHA CEU eligible courses out there, adding fresh content every week. Remember, use BRAINSTORMS20 to get $20 off access to over 1,000 courses for an entire year. Head over to SpeechTherapyPD.com for more information and start earning CEs today. Thanks for tuning in to Brainstorms Functional Neuro Rehab for SLPs. And don't forget, SpeechTherapyPD.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us. We'd love for you to drop us a quick review and hit that follow button.